Good afternoon, everyone present here. I am Faraz from IJCP Group. Welcome all the participants on today's webinar. Let's welcome today's speaker with great honor, none other than Dr. T. Nirmal Frederick, sir. And let me share some of the achievement of sir. Sir has done MBBS, MS in ophthalmology, DNB, FICO, MD at Chief Eye Surgeon at Nirmal's Eye Hospital, Chennai, Principal Accessor Accreditation Board Member, NABH QCI. And today he is going to speak on a very important topic, that is glaucoma and comorbidities, a comprehensive update and management strategies on the occasion of Glaucoma Awareness Month. So by taking not much time, I would like to invite sir and hand over this session to sir. Sir, the stage is yours. You can proceed from here.
Thank you so much, Faraz and IJCP for the invite. I'm honored to uh, present this important topic on glaucoma and comorbidities. And so you all know glaucoma is a condition that steals the sight of an individual. And not only glaucoma, it comes with so many other comorbidities. So in a garden, it's like cataract, if you like, to the weeds that can block the growth and vision of the flowers. Glaucoma is like a hidden root that can slowly damage the entire garden. So it's very important that we amend to this and see how we can protect our patients from the disease, as well as help him restore sight and hope. I'll start with few cases. A 62-year-old male with 12-year history of primary open-angle glaucoma, treated with latanoprost and dorzolamide. Still, the eye pressure is 23 and 16. If you see that the left eye is pseudophakic, has a visual field deficit over last 3 to 4 years, and right eye is hypermature cataract. And so this is the status. You also see a filtering bleb on the top. And added to the complexity is this patient is a VIP patient. This is a second case, a 56-year-old male with poor vision in the right eye and dense nuclear cataract. Eye pressure is 16 and 18, and with anti-glaucoma medication, Travatan, moderate primary open glaucoma. So the complexities and comorbidities coexist. So that leads to difficulty in approaching the patient as well as certain complexities. Glaucoma, unlike other disease, present with so many comorbidities. It can be ocular and systemic comorbidities, leading to very complicated status and high risk status, not only for the patient but also for the care providers, particularly the eye surgeons. It is compounded further by small pupil because of long-term treatment of anti-glaucoma medications, posterior synechiae because of recurrent inflammation, shallow or deep anterior chamber. Both can happen. And invariably, the zonules are weakened, particularly in patients with pseudoexfoliation. And as I said, the patient profile itself is difficult because of the age and other comorbidities. So, what are the comorbidities? So, basically, I'll first discuss the systemic partners in crime for glaucoma, and then the ocular comorbidities and how do we approach. Most of these patients are elderly patients. The commonest comorbidity is systemic hypertension. So this hypertension not only increase the risk of developing glaucoma, especially primary open-angle glaucoma, but also share several common risk factors such as aging and genetic predisposition. The mechanism of damage is the hypertension reduces the blood flow to the optic nerve and compromise the optic nerve ability to withstand elevated intraocular pressure, even in the absence of high intraocular pressure. So most of these patients present with normal tension glaucoma. So hypertension as a risk factor for open angle glaucoma is a proven entity. The capillary pressure increase and the raised intraocular pressure lead to mechanical stress on the posterior segment of the eye, thereby leading to normal tension glaucoma and ischemia. The second systemic factor or disease is diabetes. Again, one of the commonest comorbidity associated with glaucoma. It can present with this triad: diabetic retinopathy, cataract, and glaucoma. So, three types of glaucoma are associated with diabetes. One is a primary open angle glaucoma. So, diabetic patients have a higher risk of developing primary open angle glaucoma. The mechanism is vascular damage, and the fluid balance is altered. So, the eye pressure regulation is also altered. The second type of glaucoma is angle closure. So, here the lens get thickened due to cataract formation. So, the angle is narrowed, leading to angle closure glaucoma. The third aspect is neovascular glaucoma as a complication of diabetic retinopathy. The third systemic factor is cardiovascular disease. Most of these patients are elderly patients, so they do have heart disease and atherosclerosis, which increases the risk of glaucoma. So, this leads to inadequate blood flow to the optic nerve due to cardiovascular issues, and these patients are more susceptible because of the fluctuations in the intraocular pressure. As you all know, heart disease is again multiple factors: atherosclerosis, hypertension, and heart failure. So this leads to reduced blood flow to the optic nerve, thereby affecting the optic nerve and increasing the susceptibility to IOP damage. So the association between glaucoma and cardiovascular disease is quite common. The reverse is also true. Glaucoma is associated with cardiovascular disease, and cardiovascular patients do have higher incidence of glaucoma. The fourth systemic disease is sleep apnea. Of late, this particular etiology is gaining predominance because of increased risk of glaucoma, particularly normal tension glaucoma. Both inflammation and oxidative stress because of OSA damage the optic nerve structures, compromising the drainage capacity of aqueous humor. And there is also high level of transforming growth factor, which significantly affects the outflow facility. So primary open angle glaucoma is common in patients with sleep apnea, leading to optic nerve damage and vessels damage. The fifth systemic disease is migraine. Even though common in the younger group, of late we see migraine, particularly those with ARA, has increased risk of glaucoma, particularly normal tension glaucoma. So both are vascular disorders, and obviously migraine is associated with primary open angle glaucoma without comorbidities in younger individuals. The sixth systemic disease is thyroid disease. Thyroid, especially hyperthyroidism, increase the risk of developing glaucoma, and this again may affect the optic nerve because of pressure in the orbit as well as the mechanism related to intraocular pressure regulation. So thyroid disease and glaucoma is a coexisting conditions. So you have to be careful and diligent in finding glaucoma in patients with hyperthyroid. The seventh aspect is cerebrovascular disease, so stroke. Particularly patients who have tendency for stroke have impact blood supply to the optic nerve, contributing to the glaucomatous damage. And the eighth systemic disease, connective tissue disease. So most of these, we all know, connective tissue disease can affect many organs, and eye is one among them. And apart from the disease per se, connective tissue disease involving the eye, the treatment also alters, particularly the steroid usage. Most of these patients are on long-term steroid usage, and this can lead to steroid-induced glaucoma and steroid-induced cataract, and also affects the trabecular meshwork, thereby affecting the intraocular pressure regulation. And vascular dysfunction is common in rheumatoid arthritis, lupus, and scleroderma, and this leads to vascular changes in the eye and the optic nerve head perfusion. So, abnormal collagen and elastin in connective tissue disease also contributes to the glaucoma and structural integrity of the eye. So, abnormal collagen affect the sclera, the trabecular meshwork, and also increases the difficulty in draining aqueous humor. And uveitis, as you all know, is quite common in connective tissues, leading to raised intraocular pressure and damaging the optic nerve. So far, we have seen the systemic factors associated with glaucoma. So the management also differs. First, we have to control the systemic factors. Simultaneously, we have to treat the glaucoma and the mechanism to reduce the optic nerve damage. Now, let's see the glaucoma and ocular comorbid conditions. So, as I said earlier, many diseases coexist with glaucoma, and so this is like so managing a coexisting cataract and glaucoma is a common problem among the ophthalmologists. So both are leading causes of blindness. Individually, it is easy to combat them, but together, both glaucoma and cataract adds to a lot of complexity. Glaucoma surgery may accelerate cataract progression. Cataract surgery alone may lower intraocular pressure, which leads to eye pressure control in some patients. So performing both surgeries at the same time is often done, but it increases the complexity and risk of complication. So how do we go about? So these are the complexities and the challenges. Posterior synechiae, deep anterior chamber or shallow anterior chamber. As you see here, the pupil is atrophic, the iris is atrophic, rigid, non-dilating, and they also present with weakened zonules. So coexistent cataract and glaucoma produces significant challenges. Not only the comorbidities, it increases the complexity, complication, and the cost of providing care. So how do we approach? So there are so many ways of dealing with the coexistent cataract and glaucoma. So you can do cataract surgery alone or cataract surgery followed by glaucoma procedure. Then, in some patients, glaucoma eye pressure has to be controlled before cataract surgery. So, glaucoma procedure takes precedence over cataract surgery. And also, there is always a dilemma whether to do extracapsular extraction, small incision cataract surgery, or phaco, or use the high tech femto procedure. And now, a lot of laser and alternative procedures are coming up to see whether we can use laser or alternative procedure for the patients, or reduce the invasive nature of the procedure and do a invasive glaucoma surgery or combine with any other procedure. So many options are now available. So we have to carefully select what is best for the patient in that stage of the disease. So how to approach? So apart from the alternatives, 7 alternative uh, discussed before, we also need to know when, where, and how to operate. And also the type of anesthesia is important. Whether to use topical anesthesia, we are comfortable using topical anesthesia for cataract surgery, but glaucoma surgery we work on the sclera and the angle, so you need anesthesia as well. So in that case, we need to use peribulbar or add subtenon injections. For some long cases, we also need to use IV sedation or general anesthesia. And if you are doing cataract surgery, again, whether to use monofocal lens, multifocal, or trifocal is another question. So all this needs expert assessment and a diligent understanding of the patient and customized, and the procedure has to be customized according to the patient requirement. So what are the risk, benefit, and alternative? So we can have staged procedure like cataract first followed by glaucoma, or glaucoma first followed by cataract surgery, or we can do a combined procedure. So you need to know what is the effect of glaucoma surgery on the development and progression of the cataract. And in some cases, we also need to use antifibrotic agent, so in the surgical treatment of glaucoma, to prevent blood closure or blood related problem. And there's another question whether single site versus two site operation, whether we can do the surgery on the same incision or we need to select another incision, and what type of cataract surgery we need to do. And now, of course, SLT, the micro-invasive glaucoma surgery, minimal invasive glaucoma surgery, or there are certain new procedures. We also need to see whether we can use this new procedure to the patient advantage. And cataract surgery, as you all know, has certain effect on the eye pressure, particularly in open angle glaucoma patients. The eye pressure tend to reduce by at least 2 to 4 millimeters of mercury, and that sustains over a period of time and beyond 12 months, 24 months, or 36 months. So, actually, cataract surgery helps patients to control the glaucomatous damage. So, to reduce the complexity and diagnostic and management dilemmas, we have certain algorithm and approaches. Let's see how we can use that to patient benefit. So, the first instance is cataract with angle closure glaucoma. So, primary angle closure glaucoma, as you all know, it can present with acute attack. Then it has to be treated like a ocular emergency, and that time we have to, after controlling the eye pressure, we need to plan for combined surgery after stabilization of high pressure. And if the angle closure glaucoma is lens induced, obviously cataract surgery will help. We need to reduce the pressure and then go for cataract surgery. And if there is a narrowed angle or closed angle, we need to do a combined surgery, both cataract and glaucoma together. So, how do we approach this from halos to hope? And the narrow angles are known culprit for glaucoma damage in these patients. So, if we remove the cataract, the angle tend to open up, and that itself can reduce the eye pressure. The second aspect is cataract with glaucoma suspect. So here we stage the glaucoma based on field loss. So mild, moderate, and severe stage. The mild stage is no field loss with other positive parameters for glaucoma, and moderate is there is field loss with one hemifield, and severe stage there is contraction of the field in both the hemisphere. So, in early cases, proceeding with cataract surgery is more than enough. Whereas in moderate and severe stage, we need to control the eye pressure with anti-glaucoma medications and then plan for cataract and combined surgery based on control of eye pressure and field loss. So the third aspect or third algorithm is primary open angle glaucoma with cataract. So how do we approach these cases? A visually significant cataract in the presence of early glaucoma is already controlled with one or two medication. So this is the common scenario. So we have to go ahead with phacoemulsification with monofocal or trifocal IOL implantation. So this is the algorithm. Cataract surgery, if it's indicated and eye pressure is well controlled, a microincision cataract surgery or phaco surgery is the best minimally invasive glaucoma surgery because that itself can reduce the eye pressure. But we need to keep the incision small to have a good safety profile. And we also need to have diligent control of intraocular pressure. So both preoperative and postoperative spikes have to be treated. The fourth instance is cataract with primary open and glaucoma, where the eye pressure is raised. So, borderline raised intraocular pressure or uncontrolled intraocular pressure. If the intraocular pressure is borderline, controlled with medication, we can do a cataract plus procedure. So, cataract with trabeculectomy, a combined procedure. But if the eye pressure is uncontrolled, we can do a two-stage procedure. First, trabeculectomy, followed by cataract surgery. So, combined surgery can avoid multi-drug therapy postoperatively, reduces the surgery risk of two separate surgeries, and the success rate is relatively good. Right. The fifth part is cataract with primary open angle glaucoma with uncontrolled intraocular pressure. Here, there's no question of going for cataract surgery first. We have to control the intraocular pressure. So, do a trabeculectomy first, followed or the new procedures mix first, followed by phacoemulsification and IOL implantation after 3 months or several months later. So this actually reduces the risk of intraoperative complications, particularly suprachoroidal hemorrhage. The sixth variation is cataract with pre-existing bleb. So patient has already gone trabeculectomy for glaucoma, but present with cataract and ear functioning bleb. So if there is a gap of 6 months, so wait for the bleb to form completely and then proceed with the cataract surgery. And also, you need to take certain precautions to reduce iris manipulation, because if iris is inflamed in the post-operative period, bleb can fail, or a lot of proliferation can happen and the bleb can close. And there are certain high risk in patients with previous trabeculectomy surgery, particularly the zonules are weak, maybe pseudo exfoliation, and non dilatation of pupil are common. So we have to be prepared before the cataract surgery to tackle all these issues. And long-term effect of cataract surgery on intraocular pressures, it's a known thing that cataract surgery reduces intraocular pressure. We have to use that to our advantage, and also monitor the patient's intraocular pressure after cataract surgery. The Apart from these six variations, there are certain ways to deal with this patient, because most of these patients are having too many comorbidities. So we need to discuss with the patients the risk benefit alternatives. So this CCC is very, very important, not only in cataract surgery but also in uh, glaucoma with comorbidities. Communication, counseling, and consent about the options, risk, and benefit of surgery is important. A diligent preoperative evaluation is mandatory, and the post-op visit have to be frequent compared to plain cataract surgery. So we need to monitor the eye pressure, we need to monitor the blood formation, we need to monitor the intraocular inflammation, and also posterior segment evaluation is mandatory. As I said, one of the dilemma is the choice of anesthesia. You can do most of the surgeries under local anesthesia, both topical with infiltration anesthesia like peribulbar, or for some patients, you might need a general anesthesia. So the essential intraoperative requirement is, of course, a good immobile and anesthetized eye with minimal bleeding. Low vitreous pressure is important, and patient have to be comfortable because it's going to be a long procedure. Then, what is the choice of technique? In spite of new procedure being available, trabeculectomy remains the gold standard in patients with multiple comorbidities, particularly in patients with glaucoma and cataract. So we have to consider whether to use adjuvant antifibrotic agents or not. And we also take into consideration the target intraocular pressure. If the target intraocular pressure is going to be low, like in moderate glaucoma or severe advanced stage glaucomas, so we need to use antifibrotic agents or other adjuvant like Vologen to reduce the glaucoma filtration procedure failure. So I tend to use a single site or single step approach, superior phacotrabeculectomy, phonic base flap. So the blood leakage is less, the timing is reduced, but it does induces against the rule astigmatism and more inflammation. So off late we have shifted to twin site approach. So phaco is done from the temporal side, and the glaucoma or anti subscleral trabeculectomy is done on the superior side. So this offers benefit of standard trabeculectomy, a limbal-based incision, less blood leakage, and the superior trab is neutralized by temporal incision and less astigmatism. So this is the procedure. Uh, the sclera is exposed. I use a triangular flap and take a flap, and from the temporal side to do a phacoemulsification. And you see the pupil is quite small. Most of the glaucoma patient will have a rigid myotic pupil, so we have to be an expert in doing a small pupil phacoemulsification. And once the lens is implanted, go ahead and continue with the, so this is placing the intraocular lens. So the lens is manipulated into its position. Now I go ahead and with a Kelly sponge remove a block of trabeculum and do a peripheral iridectomy, and then the flap is sutured. So the anterior chamber is well formed and the flap is sutured. So this is adjustable suture, so that we can titrate the intraocular pressure post-operatively. So the technique of flap construction, so the previous case, it was triangular flap. We can also do a rectangular flap. And so this is there is no evidence that one is superior to the other. It all depends on the surgeon's comfort factor. The method of trabeculectomy, previously we used to use a knife or scissors. Now we use a glaucoma punch so that we get a clean square tissue uh, or a round tissue. We are able to know the size of the trabecular meshwork or trabeculum area we remove. So this is the Kelly sponge method. And modulating the wound healing after glaucoma surgery is important. We need to monitor the wound healing. So most of the wound can close over a period of time. So we use antimetabolites like 5-fluorouracil or mitomycin C, both intraoperatively. So this is the mitomycin, the anti-5-fluorouracil being injected, and in some cases, we also use mitomycin C intraoperatively. And also, we give this as postoperative medication. And to titrate the intraocular pressure control, we use various methods like adjustable suture and ologen placement so that the bleb remains open and functioning. So these are the glaucoma procedures, subscleral trabeculectomy being done, and the flap being sutured. And end of the procedure, we keep. So this is the ologen being placed. So ologen is a material that will reduce fibrosis and reduce the inflammation in the bleb area. So it gives a diffuse, a good bleb over a period of time. So that's advantage of this. Unfortunately, it is not available now. Previously, it used to be a good methodology to have a good bleb and diffuse bleb. So the ninth point is the summary post-operative. Apart from doing all these complicated surgeries, it's very important that we manage the post-operative complications. So we have early post-operative complication and late post-operative complication. The main factor is the intraocular pressure. So it can present with low intraocular pressure or high intraocular pressure in the early stage as well as late stage. And if in the early stage it is mostly due to uveitis or blood in the anterior chamber, that is hyphema. And if the bleb is flat or formed, we also need to understand this and look at the chamber and see if the flat bleb and flat chamber, we need to control the intraocular pressure. In flat bleb, we need to suture or secure the bleb. And in the late complications, so in patient with lens, cataract is common. Infection is a high risk in glaucoma surgeries. And if there is tight flap, raised eye pressure can happen. In that case, we need to adjust the sutures to reduce the intraocular pressure. And post-operative management, it's very important that patient is followed up frequently and look for bleb features, the anterior chamber reaction, and always check the intraocular pressure. It should be optimal, neither high nor low, and also check the media, particularly if there is a bleeding in the anterior chamber or the lens is getting cataractus. So my post-op regimen consists of antibiotics, course of steroids, cycloplegic to keep the iris and pupil quiet, and non-steroidal anti-inflammatory agents if the patient is steroid responder. And of course, lubricant has to be used because of the sutures. So the key point is select appropriate technique. Corneal good exposure with corneal traction suture is important. Pre-place scleral sutures to reduce intraoperative hypertonic, And if you're using mitomycin C, apply to a large surface area, so to reduce the risk of phlebitis or cystic blebs. And scleral flap, so whether triangular or rectangular, it helps to aid into the posterior flow. And this meticulous closure of tenons is very, very important in glaucoma surgeries. Right. So apart from management, we also need to follow the outcome indicators. Apart from patient satisfaction in restoring the sight and hope, the maintaining intraocular pressure is paramount in patient with glaucoma. So surgical approach, trabeculectomy gives a good reduction, 50% reduction in the intraocular pressure. And if it is combined with phaco and trabeculectomy, it's 30% reduction. And if you use mitomycin C, additional eye pressure drop can be seen. So there are other options like laser trabeculoplasty. This we have to select the patient, and there are many forms of mix coming up. So most of the glaucoma surgeons are now very fond of mix, and a lot of advancement coming into the cataract as well as glaucoma treatment. So we have to select the patient for the procedure as well as select the procedure for the patient. And these are some of the new procedures, non-penetrating filtration surgeries. So in glaucoma with other comorbidities, we have to be selective in selecting the procedures. This is the express shunt is available in case we need a proper shunt to filter the aqueous. And the newer glaucoma procedure, that's basically meant for early glaucomas with or without cataract surgery. So you have gel stent, you have hydrus, eye stent, and the eye stent, CyPass. So many variations are now becoming available. So basically, management of cataract and glaucoma, these are my checklists. So stage the glaucoma in both eyes, note the intraocular pressure, do a serial recording of intraocular pressure, and do a proper fields and optic nerve head analysis. Perform gonioscopy, re-evaluate the condition of the angle at every stage. And if it is narrow angle and eye pressure reduced, so consider goniosynostosis during the procedure. And always do a gonio after cataract surgery. Review the medication. Review patient frequently, particularly the comorbidities, compliance and follow-up is important. And we always need to keep talking to the patient. So under promise and over deliver, and document all the findings as well as the post-operative care. So a system for management of patient with cataract and glaucoma, we need to treat the patient, not the abstract concept, the intraocular pressure, because the person is a reality, is not just an entity or case. We need to answer these four questions before we select the procedure or medication for this patient. Who's this patient? How can I preserve or enhance this person's health? Does this person have a complication? To what extent? What are the factors controlling the eye pressure, optic nerve function in this patient? So all these are really important before we take the patient for surgery or continuous management. So the art of medicine matters just as much as the science in managing glaucoma patient with so many comorbidities. So essentially, we need to customize the glaucoma therapy for the patients. So to conclude, glaucoma with comorbidities is a entity that we commonly come across. We need to use our knowledge and experience and expertise to guide the patient to proper care to restore sight and hope. Thank you so much. If there are any questions, I'll be happy to take.
Thank you so much, sir, for your valuable time and sharing your knowledge on this topic. I definitely think this session knowledge is going to help all the participant on their practice also. Sir, as I can see, sir, we have received some question related to this topic. With all your permission, shall we take
Yes,
forward?
yes, Saras.
Yeah, thank you so much, sir. And our first question is from Dr. Subramaniam. He is asking like being a physician, it's very difficult to understand the things related to glaucoma. And what will be the first approach to refer the doctor to ophthalmologist? What should be the clinical examination need to be done?
Okay, Dr. Subramanian, that's a wonderful question. So basically, you deal, being a physician, you know all the systemic conditions. So you have to be aware that so if the patient has multiple systemic conditions, so he or she can have glaucoma. So any form of glaucoma, it may be angle closure or primary open angle glaucoma. So you need to treat the systemic condition and ask the patient to get a ophthalmic evaluation done on the particularly on the eye pressure, the glaucoma evaluation for the staging, and what type of medications the patient would require. And post treatment or during the treatment, whether it is a medical management or surgical management, we all have to work as a team. So on your part, you need to take care of the systemic aspect, controlling the blood pressure, optimizing the blood sugar control, and if there are any cardiovascular abnormalities, you need to treat the cardiovascular abnormalities. We in turn will take care of the target intraocular pressure and also maintain the status of the optic nerve to have a good perfusion and maintaining the sight. So we need to work together. So you need, need not know about the glaucoma procedure, but I am sure the first part of the presentation would have been useful to you.
Thank you so much, sir, for answering. I hope that Dr. Subramaniam has received his answer, sir. And thank you so much, sir, for answering his question. Moving forward, I can see another question from Dr. Singhania, and he is asking, like, sir, after proceeding towards the post-operative care, like, what are the things we need to tell the patients to take care after the operation, sir? What's your point of view on that?
Yeah. From the ophthalmic point of view, the patient has to come for regular eye checkups to monitor the intraocular pressure, to check the status of the angle. So gonioscopy has to be done. We also need to see the fields and the optic nerve head. So this glaucoma evaluation on a periodic basis is important, and it depends on the stage. If it is the early stage, we can monitor only the intraocular pressure and the optic nerve head evaluation every 6 months or so. But in moderate or advanced stage of glaucoma, we need to follow the patient more frequently. The eye pressure also have to be optimized, and we also keep in consideration the optic nerve at perfusion, particularly patients with hypertension and cardiovascular disease. We have to optimize the blood circulation also, because there the eye pressure will be normal, but the perfusion to the optic nerve head will be compromised. So we have to take in control the systemic factors also.
Thank you so much, sir, for answering this question, sir. I hope that, like, Dr. Singhania has received his answer. Sir, moving forward, sir, we have another question from Dr. Shruti, and she's asking, what is the US prevalence of phacolytic glaucoma, sir? What's your point of view on that?
The phacolytic glaucoma, the incidence is now coming down because so when we graduated, used to be at least 5%, right? But now with eye centers proliferating or the access to eye center have increased, the incidence of phacolytic glaucoma has come down. So now it may be less than 0.5 percentage in urban India, and maybe 1 to 2 percentage in rural India. The in US, I think the level is somewhere less than 1 percentage. So very rarely people go for phacolytic
Yes,
glaucoma
sir.
nowadays.
Thank you so much, sir, for answering all the question. As I can see, one last question from Dr. Agnihotri, and he is asking, like, how is intraocular pressure, that is IOP, measured in the ovulation of glaucoma suspect, sir?
Okay, so there are tonometries available. So the gold standard is the applanation tonometer or Goldman applanation tonometer, which is available in most of the glaucoma centers. In the ophthalmologist clinic, we have non-contact tonometers or handheld tonometers, so which can measure the intraocular pressure. So this is used for the evaluation, screening, as well as monitoring the intraocular pressure. In many centers, home tonometry is available, particularly patients who are having very high diurnal rhythm variations. We advise home tonometry, but in India, the availability is restricted to certain centers. So home tonometry will be a boon if it comes, like home blood pressure monitoring or home blood sugar monitoring. If we have home tonometry, it will be easy for the patients. I hope really some new age technologies will catch up with this.
Thank you so much, sir, for answering all the questions. As I can see, there is no more question, and Dr. Subramaniam has written one feedback. Wonderful session. Thanks for responding to my answer.
Thank you, Dr. Subramaniam.
And sir, like as I can see, there is no more question. I hope you have done justice to this topic. That's why we don't receive further questions. And sir, as there is no more question, with all your permission, shall we conclude this session for today?
Yeah, thank you, Faraz. Thank you for the invite. And so in March is the glaucoma awareness month. So
Yes, sir.
World Glaucoma Week is celebrated on the second week of March, from 9th March to 15th March. So this is a disease that needs a lot of advocacy effort from all of us.
Yes, sir.
I'm sure the participants in this, and so I'm sure you'll be hosting in the website. So
Yes, sir.
hopefully people can see this and get benefited. Thank you so
Yeah, sir.
much. Let's work together to restore sight and hope for these patients.
Yes, sir. Welcome, sir. And we would like to see you in future also with different topic. Till then, take care of yourself, sir. It was a really great honor to have you, sir, on our platform. Thank you so
Th-
much.
Thank you, Faraz.
Bye, sir.